I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Prostate cancer affects 1 man out of 8 over a lifetime. How has detection or treatment changed in recent years? This is the People's Pharmacy with Terry and Joe Graydon.
Dr. Andrew Armstrong is one of the country's leading prostate cancer researchers.
The good news is that treatment can extend life, often dramatically, and that many men, most men in fact, with prostate cancer don't die of prostate cancer. They die of other stuff.
Has former President Joe Biden's diagnosis of metastatic prostate cancer changed our awareness of this disease?
Coming up on the People's Pharmacy, what men need to know to overcome prostate cancer.
In the People's Pharmacy Health Headlines. The COVID pandemic is over, but too many people are still suffering from long COVID. A new study demonstrates that even mild infections may lead to symptoms many weeks or months later. Researchers studied rhesus macaques. Even though they were unvaccinated, the animals did not become very sick when they were infected with COVID-19, and they recovered promptly. But 6 months later, many of them had signs of chronic illness. The scientists noted that there was evidence of persistent viral RNA in nose and mouth tissues, as well as stool, indicating persistent infection of the digestive tract. The monkeys had elevated markers of inflammation and hormones indicative of diabetes and heart disease. In addition, many were not sleeping well. All of the animals showed signs of changes following infection, but those that were obese fared worse. Specifically, they had persistent lung pathology, even if they were not having trouble breathing. The investigators conclude that their study suggests that the true prevalence of PASC, that's the technical term for long COVID, in the human population may be significantly underestimated.
A new study in JAMA confirms that lifestyle matters when it comes to cognitive function as people age. Investigators recruited more than 2,000 volunteers at 5 clinical sites in the United States. They were between 60 and 79 years of age and at higher risk for dementia. That's because these recruits had a sedentary lifestyle and a suboptimal diet. In addition, they had other risk factors, such as a family history of memory impairment or metabolic problems. Half the recruits were randomly assigned to a structured lifestyle intervention program. The other half were on their own in a self-guided program. Those who participated in the structured group received aerobic, resistance, stretching, and balance exercise training at a community facility. They were encouraged to follow the MIND diet, a combination of a Mediterranean and DASH diet approach. In addition, the structured lifestyle intervention group got cognitive training on computers and participated in socially engaging activities. Both groups showed improvement in their cognitive scores, but the people who had intensive interventions did significantly better over the 2 years of the study.
Do you take 10,000 steps a day? Many people have adopted this as a goal, even though it was originally developed as a promotional slogan for a Japanese pedometer company. Now, scientists have studied the effects on health of daily step counts. A meta-analysis found that increasing steps beyond 2,000 a day reduces the risk of cardiovascular complications, cancer, and death due to any cause. However, the optimal count is around 7,000 steps. Doing more than that offers only a slight increase in benefit.
Researchers have been debating the safety of SSRI-type antidepressants during pregnancy for decades. The dilemma has been that untreated depression during pregnancy puts both mother and fetus at risk. But a panel that met at the FDA this week cautioned that SSRI-type drugs could potentially harm developing babies. Concerns were raised about cardiac birth defects and possible cognitive consequences. There were also warnings about postpartum bleeding. The American College of Obstetricians and Gynecologists responded that most research shows SSRIs are safe during pregnancy. No woman should stop such medications suddenly, as this could result in severe withdrawal symptoms.
Atopic dermatitis, the medical term for eczema, can make babies miserable. Patches of skin become red and itchy, and babies may scratch at it. The itch may also keep infants and their parents awake. A randomized clinical trial has found that early use of moisturizer can reduce the chance of a baby developing eczema. This multi-center study had almost 1,250 babies, with half getting moisturizer starting at 9 weeks and half without. Those who got moisturizer had a lower likelihood of eczema at 2 years. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. When former President Joe Biden was diagnosed with stage 4 prostate cancer, a lot of people were surprised. They may have assumed that a president would be monitored for most common health problems, and prostate cancer affects 1 man out of 8 during his lifetime.
There have been some very important prostate cancer discoveries over the past few years. Many more men are in a good position to survive this cancer if they can take advantage of the latest approaches to diagnosis and treatment for this very common cancer.
Our guest is Dr. Andrew Armstrong, professor of medicine, surgery, pharmacology, and cancer biology. He serves as director of research at the Duke Cancer Institute's Center for Prostate and Urologic Cancers.
Welcome back to the People's Pharmacy, Dr. Andy Armstrong.
Thank you, Terry. It's a pleasure to be back with you today.
Dr. Armstrong, I think the nation was shocked. I know we were to learn that former President Joe Biden was diagnosed not just with bad prostate cancer, but really advanced metastatic prostate cancer. It had, I understand it, gone into his bones. How was that possible? He gets the best medical care in the world.
Well, Joe, prostate cancer is the most common cancer among men in the U.S., so it's not a surprise that as a man gets older, he's facing other obstacles. Prostate cancer is one of the biggest challenges that many men in America face. And fortunately, we have ways to pick this up early through screening and early detection, but many primary care doctors stop screening at a certain age, stop that process of early detection. Well, there's the general feeling that men may not live long enough to see the benefits of screening. There's all sorts of competing causes of mortality that we all face, as we age, cardiovascular disease particularly. And the prostate cancer is commonly picked up early before it causes harm. And that's the benefits of screening, before it leaves the prostate and spreads to other parts of the body. And that can save lives, but it often takes 10 or 15 years to see a survival benefit with screening and early treatment. And so as a person ages, into their approaching 80s and 90s, the benefits of screening diminish. That doesn't mean that the cancer goes away. In fact, as you survive longer and longer, it becomes a more important part of what you could face in your health. And so, certainly from the president's perspective, this is now a very important and pressing issue that requires immediate treatment.
What I think shocked me the most, and I don't even know if this is true, but the headlines were saying, former President Joe Biden, the last time he had a PSA test was 2014.
Now, before we go any further, we should talk about what a PSA test is and what it tells us.
That's a great point, Terry. So PSA stands for prostate-specific antigen. It's not a correctly named protein in that it's not prostate cancer specific protein. Although we use it to screen for cancer, it's also produced by normal cells of the male prostate. And many men can have elevations in PSA without cancer, such as a big prostate or inflammation of the prostate called prostatitis. But it's also a marker of more aggressive disease and having cancer. And so we use it to identify men who may be suitable for more testing, such as MRIs of the prostate to guide a biopsy. And then the biopsy is the gold standard for diagnosing prostate cancer along with the imaging. And, so many men will stop screening when the benefits are perceived to be lesser. What he made that decision on based on recommendations from his primary care physician and team, I don't know. Certainly a president, we would want to have screened for all sorts of conditions that could crop up during a reelection. But I don't know the details of when, screening was stopped. And he may have had a very low PSA, back at that time. And so the benefits at that time were perceived to be low. And I don't know what his PSA ended up being. There are some cancers that don't make a lot of PSA, and can still be aggressive and spread. The more important thing is, what are we going to do now? He needs treatment. And the good news is that treatment can extend life, often dramatically, and that many men, most men, in fact, with prostate cancer, don't die of prostate cancer. They die of other stuff.
What would you have recommended had you been his, let's just say, his physician for oversight? If you were monitoring someone who was fairly important in the world, some people would argue very important, how often would you have recommended a PSA test? And tell us a little bit about the Preventive Services Task Force. And did that entity kind of get people into trouble by, shall we say, diminishing the importance of a PSA test?
Let me answer your first question first. And, every patient in my practice is important. And, I think that's one of the most important features is that when a patient has prostate cancer, they bring with them their own comorbidities, preferences, side effects that they wish to avoid, medical conditions, other medicines they're taking. And so for every patient, it's a very personalized treatment decision, and it's sculpted according to their personalized issues that they're dealing with, their age, their health, what quality of life issues that they wish to avoid and approach, their stage, and how aggressive their cancer is. And so for a man who is elderly, who's facing a lot of other medical issues, who may be now faced with stage 4 disease, which is not a curable condition, the main focus would be on extending life, but also maintaining quality of life so that he can face other medical problems with dignity and, not have his quality of life deteriorated. So the front line of prostate cancer treatment, which we've known since the 1940s, first Nobel Prize in all of cancer, is hormonal therapy. The front line is to deprive prostate cancer of testosterone.
I'll get back to that in a second, but I want to go back to the idea of screening. And so, imagine a man who's in his 50s, and now we understand there's more and more prostate cancer being diagnosed in younger men. How often should he go in for a blood test just to get that basic PSA, even though it's not, perfect? It's not going to identify every prostate cancer. But how often? What about men in their 60s? What about men in their 70s? And in the case of Joe Biden, a man in his 80s. Give us some sense. Once a year, once every 5 years, once every 10 years. And then back to that Preventive Services Task Force. What is it, and what did they recommend, what was it, several years back?
Sure. It's important to start with the realization that prostate cancer generally doesn't develop in the 20s and 30s and very rarely in the 40s. The average age is about 66. And so most guidelines recommend screening starting around the age of 50, although there are guidelines that recommend a midlife PSA in the 40s to really get a risk assessment. It's kind of like having a colonoscopy and finding out in your 40s you have a few polyps. You may want to get a colonoscopy more often because your risk is higher. Just like having a slightly higher PSA in your mid-40s. That may inform on how often to be screened. And So, and there are higher risk populations. Those with a family history of various malignancies like breast, ovarian, and prostate cancers have a higher risk and may want to be screened earlier. African American men have a higher risk of prostate cancer, may choose to get screened earlier. It's all about the trade-offs, what other competing causes of mortality you face. But certainly in the 50s, we recommend annual screening. It's part of informed decision making. It should be discussed as part of the annual wellness exam with your primary care doctor. That PSA will then dictate how often you're getting PSAs. And if it's normal, less than 3, for example, in a patient in their 50s and 60s, then we just move to either annual or semi-annual screening. But the PSA does go up with age. The prostate gets bigger with age, and so you adjust and use age-adjusted cutoffs so that a man in his 70s, the normal cutoff might move up to 6 to 7 as a means of determining what's abnormal and who to get a biopsy on.
And the PSTF, the Preventive Services Task Force, they made some recommendations that a lot of urologists were unhappy with.
There were some initial recommendations that pushed back on screening and downgraded prostate screening to Category D. Now, that was reversed in recent years to more push for an individualized, personalized, informed decision-making. And during that initial recommendation to downgrade prostate cancer screening, we did see an uptick in the prevalence of metastatic disease in our country. And now that we've, reinstituted prostate cancer screening, we're starting to see that reduction, along with, other factors that were happening like COVID, which reduced screening for most cancers among the population.
And that Preventive Services Task Force recommendation might have played a role in the decision that
Absolutely.
Former President Biden and his doctors made not to follow up on his
these
screening.
recommendations are living documents based on the best evidence we have at the time, and it's great that they changed their opinions as the data matured, and we show that prostate screening does save lives.
That's what science is about, isn't
Absolutely.
it? We have to change as the data change.
Absolutely.
We have just a minute left before the break. There is something you mentioned called a MRI. Why is that so important?
So think about when women go for screening for breast cancer, they will get mammograms. There is no real prostagram. Regular old X-ray imaging of the prostate is not sensitive enough to pick up the tiny little lesions that are prostate cancer. An MRI is like a high-definition TV set image of your prostate and can pick up with fine detail the characteristics of malignancy, allows the urologist to place the needle and hit the target to identify the cancer instead of blindly sticking needles into the human gland, which may miss cancer. So it's more accurate and more sensitive, and it can avoid, detecting cancers that are less clinically significant.
You're listening to Dr. Andrew Armstrong, professor of medicine, surgery, pharmacology, and cancer biology. Dr. Armstrong is Director of Research at the Duke Cancer Institute Center for Prostate and Urologic Cancers. He holds positions in the Departments of Medicine and Urology at Duke University.
It's time for a short break. In just a few moments, we'll learn more about how doctors grade prostate cancers. What is a Gleason score?
And how serious is Joe Biden's stage 4 prostate cancer?
Are there new tools for early detection?
We'll also talk about prevention. What can men do to reduce their risks for this kind of malignancy?
Do we know why more men under 50 are being diagnosed with prostate cancer?
You're listening to The People's Pharmacy with Joe and Terry Graydon. This episode of The People's Pharmacy is brought to you in part by Sonu.
If you or someone you love struggles with nasal congestion, whether from allergies, chronic sinus issues, or even pregnancy-induced rhinitis, there's finally a drug-free, FDA-approved solution that actually works.
Sonu is a wearable headband that uses personalized sound-based therapy to open nasal passages and to improve airflow in minutes. It's backed by clinical research, developed by a Stanford rhinologist and physician, and safe for anyone ages 12 and up. No steroids, no sprays, just natural, fast relief.
You can learn more at GetSonu.com. getsonu.com. That's getsonu.com.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Sonu, an FDA-approved drug-free treatment for nasal congestion and runny nose, a sound-based alternative to steroids. More at getsonu.com. That's getsonu.com.
Over the last decade or so, diagnostic tools for detecting prostate cancer have improved substantially. For one thing, the FDA has allowed magnetic resonance imaging, or MRIs, to be used to detect potential tumors and guide prostate biopsy.
There are also newer drugs that can make a big difference in outcomes for men with prostate cancer. And there is a potential game changer for someone like former President Joe Biden, who has metastatic disease.
We're pleased that our guest today is one of the country's leading researchers in this field. Dr. Andrew Armstrong is professor of medicine, surgery, pharmacology, and cancer biology. He's director of research at the Duke Cancer Institute Center for Prostate and Urologic Cancers, and holds positions in the departments of medicine and urology at Duke University.
Dr. Armstrong, you just mentioned a biopsy. So that's, I assume, if you see something a little suspicious on that MRI, and it's like, what's going on? What is that spot? That allows the urologist to go in very targeted and look at that particular spot with a biopsy to see if there is, in fact, something happening. Am I right?
Yeah, the older way of doing a biopsy was with an ultrasound device, and that was typically not seeing the cancer at all, but rather biopsying throughout the prostate in a grid to identify the source of the high PSA and whether there was cancer. That frequently led to both overdiagnosis of small cancers that were clinically insignificant and underdiagnosis of the important cancers you want to find. The MRI solves that problem by identifying those cancers where you can place the needle and be more accurate. The MRI is not perfect, so we still biopsy in other areas because there can be small tumors that don't even show up on the MRI. So the present way of doing biopsy is using the MRI to inform the biopsy, but not only MRI guided.
So a biopsy gets cells, and a pathologist looks at the cells and says, okay, these cells look fine, or, ooh, these cells really don't look very good. Tell us a bit more about that, if you would,
Yes.
please.
Donald Gleason was a veteran and VA doctor who identified that prostate cancer was very heterogeneous, meaning you can have multiple cancers in the same gland, and he established a grade group score, a Gleason score. And that grade group that we use characterizes how aggressive the cancer is under the microscope. It's one of the most important factors in both diagnosing and identifying the risk that that cancer has to the patient, along with the PSA and the stage. And the stage means how extensive the cancer has spread within the prostate, outside the prostate, and into distant parts of the body.
Now, I understand that former President Biden had a Gleason score of 9 and a stage 4. So help us understand stages 5, 6, 8, 9, 10. Put it into perspective.
Sure. It's important to separate stage and grade. So grade goes up to 10. All right. So the higher the number, the more aggressive the cancer looks under the microscope. Stage goes up to 4. Doesn't go beyond 4. So stage 4 means a cancer of an organ that has spread to distant parts of the body. So the doctors who diagnosed Joe Biden found a more aggressive cancer, and it was also confirmed to be aggressive because it had spread to the bones.
How did they know that?
Typically, to pick up spread, to stage a patient, you do imaging. A more modern way of doing imaging is a prostate-specific PET scan. This it's a full body scan. A lot of patients will get this, once they're diagnosed with prostate cancer, particularly if they have a more aggressive form of prostate cancer. This PSMA, or prostate-specific membrane antigen, is a way of identifying where the PSA is coming from. It's very prostate specific, although there are many organs in the body that express PSMA. It can lead to some false positives, but it's used to identify where the cancer is. A patient who has a normal PSMA scan and the cancer's just in the prostate may be a great candidate for surgery or radiation to try to cure them. A cancer that has spread, may not be a candidate for radiation or surgery, but can still be treated very effectively and go into remission.
We have been talking about a specific case of a person whose prostate cancer was not detected early, not detected until it had already spread outside the prostate. Can you tell us about the tools that you and your colleagues use for early detection?
Early detection is best solved through both imaging, like this MRI, and PSA screening. So it's part of the annual exam is to use that blood test to identify patients who may benefit from further testing. There's other ways to identify who might benefit the most from screening, such as genetic tests. But right now, the PSA is still our best test.
Let's go back to that genetic test for a moment, because when they do a biopsy, they get tissue. And they can look at the genetic variability. What does that tell you?
Yeah, if you have 100 patients all with prostate cancer and you do these kind of DNA genetic tests, you find 100 different answers. And that just speaks to both our ancestry being different from each other and also the cancer risks. So some patients will inherit mutations, for example, in the BRCA2 gene, which is a breast and ovarian cancer gene in women, but also a prostate cancer gene in men. And there are many other variants that are mutations that confer cancer risk. So the vast majority of men who are interested in these kind of questions for their family and siblings should be offered genetic testing to figure out why they got prostate cancer. About half of prostate cancer is hereditary and half is environmental, meaning it's caused by lifestyle or exposures that confer higher risk.
Well, I know a lot of our listeners are going to want to know about prevention. What can they do in terms of lifestyle?
Yeah, this is a great question. Now, you can't change your genes, but you can change your behaviors. And screening is one of those important behaviors. Seeing your medical doctor and being screened can reduce your risk of dying of prostate cancer. But lifestyle, your own personal lifestyle can play a role. Now, some of the established risk factors for aggressive prostate cancer happen to be obesity, being overweight, smoking, lack of exercise and being sedentary, lack of certain vegetables. The cruciferous family of vegetables has been associated with a...
So if you are a broccoli hater like former President George H.W. Bush, you're in trouble.
Well, there's no perfect diet. There are certain dietary patterns that are associated with reduced risk, such as being a vegan or vegetarian, but I wouldn't necessarily recommend that all patients, do that. There's slight gradations of risk with different dietary patterns. In general, a healthy lifestyle, maintaining a healthy body mass index, not smoking, exercising, and eating a healthy diet will probably prevent about 60% of all malignancies, including prostate cancer.
I want to come back to that exercising piece, because we've been reading a lot lately about the importance of exercise, both in preventing cancer and after treatment.
And in treating cancer. There was an article published fairly recently in the New England Journal of Medicine on people with colorectal cancer who got tremendous benefit from exercise.
I think that's a really important study. It's not a pharmaceutical. It's something that patients can empower themselves to do regularly with some guidance. Patients need advice on how to exercise, but with guided exercise training, you see effects on survival equal to that of some of our best therapies.
Well, what surprises me is that cardiac rehab is just taken for granted after someone has a heart attack. Insurance pays for it. Everybody goes, yeah, absolutely, you've got to go to cardiac rehab. When a man has prostate cancer, that's not assumed, and insurance doesn't pay for it.
Yeah, wouldn't it be wonderful if insurance covered preventative health care like gym
should.
membership? It absolutely should, because it has such a major effect on so many factors: obesity, heart disease, bone health, muscle health, depression, anxiety, but also cancer risk.
Do we know why? We have alluded to the idea that more younger men under 50, are now being diagnosed with prostate cancer. Do we know why?
We're starting to see early onset of multiple malignancies, particularly colorectal cancer, and prostate cancer is not unique to that. And we worry that it may be caused by things that we're poisoning our environment with. Our
environmental toxins.
Yes, which we also consume in our poor diets as Americans.
Mm-hmm.
There's a lot of processed foods. There's a lot of unhealthy additives. There's, just sugar, high fructose corn syrup. There's a lack of exercise. There's the canceling of gym class in public schools. There's all sorts of convergent things that are keeping our children on their phones, our adults on their computers, on their video games, and keeping them out of the gym or the weight room, or keeping us out of in-person interactions, which I do worry may be contributing to a lot of health conditions.
Well, there's also microplastic. And, I'm old enough to remember the Dustin Hoffman film in which he is advised that plastic is the future. And now here we are, and we have microplastics, nanoparticles of plastic throughout our body, including our genitals. And one has to wonder, well,
how much plastic is in the prostate?
Yeah.
There probably
It's
is
a great question. I've wondered this myself. You see plastic contributing to cardiovascular disease and is
Yes.
actually embedded in our coronary arteries. A lot of prostate cancer is thought to be due to underlying inflammation, which plastics can certainly involve. And I think that's an area of great research interest if we can reduce those exposures, not just the plastic itself, but there's things called plasticizers.
Yes.
We had a publication last year with Dr. Samarelli at Duke who identified the things that leach out of plastics as being equally harmful and cancer causing that keep the plastics together. These are called plasticizers.
Let's talk about treatment. It has changed dramatically since my uncle, who was a farmer, developed prostate cancer in his probably 60s. He was given something called DES, diethylstilbestrol, a estrogenic type of compound. I don't suspect you and your colleagues prescribe DES anymore.
No, when DES was under study in the VA health system, it was a remarkable treatment that provided a way of lowering testosterone. In the 1940s, men had their testicles removed. And then in the 70s and 80s, the advance of other ways that were reversible through working through the pituitary gland. These are called GnRH agonists or antagonists, leuprolide, for example. Synthetic chemicals that basically can temporarily reduce testosterone without all the harmful effects of estrogen that can cause blood clots. And the advances on top of that are through chemistry that design drugs, blockbuster drugs that block the androgen receptor, which is important in most prostate cancer. And further blocking hormonal therapy has extended the lives of our patients, not by months, but by many years.
So if you were in charge of former President Biden's treatment, and of course you are not, so this is purely speculative, but if a patient did come in with stage 4 and a Gleason 9 and metastatic disease in the bones, what would you recommend?
I think the first thing is to reassure patients that, a lot of patients come in with great fear. They're fearing an immediate death sentence when they hear the word stage 4 prostate cancer. I saw patients last week that have been living with stage 4 prostate cancer for up to 26 years.
Wow.
So
Exactly.
not immediate death.
Not immediate death. So you better get on with living. Don't forget about your exercise. Don't forget about your diet. Don't forget about, planning time with your family and loved ones. The hormone therapies that we have that can control this disease help men live many, many good years. Not chemotherapy necessarily for all patients. There are advances beyond hormonal therapies, such as these pills that block the androgen receptor, adding additional years. There are certain drugs that I might pick for
such as
the 4 androgen receptor pathway inhibitors go by different names. The generic names are enzalutamide, apalutamide, darolutamide, and abiraterone. These are all phenomenally effective and have extended the lives of patients globally. For some patients, one may be better than another. There are certain agents that don't get into the brain, don't cause memory problems, don't cause fatigue or significant comorbidities.
Which are those?
So darolutamide for an older patient is a drug that extends survival, but without a lot of side effects. It's a good choice for an
Do
older
you have
patient.
a brand name? Because people will, what did Dr. Armstrong say? That rolled off his tongue.
Darolutamide.
Yeah.
How do I spell that?
So the 4 drugs I mentioned are Xtandi, Erlita, Nubeqa, which is darolutamide, and Zytiga. Many are going generic, so it's important to remember both names. All drugs have both names. And like I said, they're all winners. They all extend lives. They have different side effects. So for a younger patient, I may pick one drug. For an older patient, I may pick a different drug.
And we'll put all those names up on the website so people will be able to figure out what we're talking about.
Dr. Armstrong, we understand that Duke has been conducting a study that they call ARCHES. I should say that you all call ARCHES.
Mm-hmm.
I have no idea why you call it that, but it's an important study. Would you tell us about it,
Yes,
please?
ARCHES comes from an acronym where AR, androgen receptor, was the first 2 letters. And this was a trial that we launched over 8 years ago. It was a randomized trial testing whether one of these drugs, called enzalutamide, now called Xtandi, could extend the lives of our patients as compared to the standard kind of weaker hormonal therapy that we had back then. We did a nice story, recently on the updated 5-year survival outcomes, which we show has dramatically been improved by this regimen. So men are living longer, they're progressing more slowly, they're going into remission in a much deeper way that allows their quality of life to be maintained. We have a patient out on the Eastern Shore who was interviewed for this story, who's now 8 years out with a PSA of 0, and he's quite happy as a national park ranger. So very, much a way to keep patients in remission. So for the president, I'd love to have him hear some of these stories of patients who can survive with good quality of life despite that diagnosis.
We just have about a minute before the break, but there are side effects. And I'm guessing that when you suppress androgen, that is to say testosterone, men feel differently. Can you give us a quick overview in the minute we have before the break?
Yes, testosterone is really important for bone health and for muscles. That's why some athletes may cheat and has a performance-enhancing drug. And so when we take testosterone away, you see a loss of muscle mass, a lot of loss of stamina. Some men describe it as the wind leaving their sails, So it's really important to emphasize exercise. Exercise reduces the loss of muscle mass, loss of bone density that you can see. It actually improves hot flashes and mental well-being, cardiovascular health, to name a few. So if you had one antidote to the hormone treatment, it would be regular aerobic exercise. Now, that's very individualized, as we mentioned. Some patients don't exercise at all, and so just getting them to go for walks. Some patients want to do more, and the more the better. There's really a nice dose response to maximizing exercise.
You're listening to Dr. Andrew Armstrong, professor of medicine, surgery, pharmacology, and cancer biology. Dr. Armstrong is director of research at the Duke Cancer Institute Center for Prostate and Urologic Cancers. He holds positions in the departments of medicine and urology at Duke University.
It's time for a short break. When we come back, we'll talk about how blocking testosterone can affect your sex life.
We'll also find out what you could do about that side effect.
What kinds of non-hormonal treatments are there?
We'll discuss the different types of radiation that can be used to treat prostate cancer.
And you'll find out about a new therapy called Pluvicto. Can immunotherapy work against, metastatic prostate cancer?
You're listening to The People's Pharmacy with Joe and Terry Graydon. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Sonu, an FDA-cleared, drug-free treatment for nasal congestion and runny nose, a sound-based alternative to steroids. More at getsonu.com. That's getsonu.com.
Prostate cancer is often treated with medications that block the body's ability to create testosterone. How does that impact everyday life?
We're talking with Dr. Andrew Armstrong, professor of medicine, surgery, pharmacology, and cancer biology. Dr. Armstrong is director of research at the Duke Cancer Institute's Center for Prostate and Urologic Cancers. Dr. Armstrong holds positions in the departments of medicine and urology at Duke University.
Dr. Armstrong, we've been discussing the side effects of depleting the body of androgens, testosterone, and a while back there was a spate of television ads for increasing testosterone in the body. They all pretty much implied that increased testosterone improves your sex life. So I'm assuming, and I should not assume anything, that there's a potential impact on the sex life if you deprive men of testosterone. Is that true? And if so, is there anything you can do about it?
Yes, Terry, unfortunately, one of the major side effects of prostate cancer therapies is an impact on what we call libido or sexual interest, as well as erectile function. And hormone therapy tends to reduce that interest in sexual intercourse. Surgery and radiation can reduce erectile function. Together, if you're combining some of these things, it can be a double hit on some men, reversibly so. So for men who are on short-term hormones, there's a recovery in most men. With surgery, there can be a recovery within a year or two after what we call radical prostatectomy. With radiation, there can also be recovery. And there are many ways, supplements, medicines, to help accelerate that recovery in erectile function. But you're right, sexual interest can be impacted by hormones. For a patient who's going to be on long-term hormonal therapy, there are men who can still, have sexual intercourse and still have important relationships with their significant other, but it can be a battle. It can be an ongoing struggle, and that's one of the impacts of negatively on quality of life, and why there's so much interest in non-hormonal therapies to tackle prostate cancer.
And what kinds of non-hormonal therapies are available?
Well, first off, if you back up and say, what percent of men are cured of prostate cancer, it's probably 6 out of 7.
Okay.
And that's because of surgery and radiation, which generally does not involve hormonal therapies.
Mm-hmm.
So the vast majority of men are cured of prostate cancer, don't need to worry about necessarily the long-term hormonal therapies. Makes prostate cancer the number one survived cancer in America. But because only one out of 7 will relapse and ultimately develop lethal prostate cancer, it's still a really impactful disease in terms of mortality in the United States. So non-hormonal therapies that are under development for prostate cancer involve immune therapies, chemotherapies, what I like to call smart bomb therapies, or radiation precision weapons. There's a lot of oral therapies that are molecularly targeted, matched to a man's personal genetic profile that are now approved and extend life. We're working on moving these earlier into curative intent settings. And the best way to address stage 4 disease is never to get it in the first place. And if you can move these therapies earlier and prevent stage 4 disease, I think you'll see a much bigger public health impact than waiting for stage 4 disease and then treating it.
It sounds like there are so many options that a lot of men might feel overwhelmed. So let's say it's not stage 4 and it's not metastatic, but it is cancer. And the MRI says, yeah, there's a problem here. You might have a PSA test of 7, or a Gleason score of 7, rather. What do you tell your patients? How do you help them make a decision? Surgery, or if it's radiation, what kind of radiation?
And what about the idea of, what's it called? We used to call it watch and wait, but that's not what it's called. Active surveillance, I think that's the proper term, has been offered as an alternative for men whose PSA is not so very high, whose Gleason score is pretty low, men who don't appear to have aggressive prostate cancer, even though they do have prostate cancer. Is that a reasonable approach?
It absolutely is. Probably 30 to 50% of men are initially diagnosed with a form of prostate cancer that is not immediately life-threatening, that is considered more indolent or benign. And these men can be recommended to have active surveillance where they're carefully followed with PSA and serial MRIs and biopsies and can avoid the side effects and harms that we're talking about, sometimes for 5 or 10 years. Now, on the flip side, there are highly individualized decisions because some prostate cancers come in more aggressive flavors. Some are intermediate, where you can have an opportunity to cure that patient early and they need treatment, so they don't meet the criteria for active surveillance, which would be a very low grade, low PSA, low stage cancer. Now, patients with the Gleason 7, those patients face shared decision making. They need to hear about the risks and benefits of surgery, radiation. There's external radiation, stereotactic beam radiation, brachytherapy.
Whoa.
Yes, lots of terms.
Yeah, let's
Yes.
walk back. Stereotactic. What does that mean?
So radiation used to take about 2 months every day going to the doctor, and now it can take less than 2 weeks.
Oh, how does that work?
Well, we've learned over time that prostate radiation can be more precisely delivered without increased toxicity, with more image guidance, with more dose delivered to the prostate in a shorter amount of time. And these fraction sizes have dramatically shrunk. In my career, just in the past 20 years, you're seeing patients really finish in 1 to 2 weeks, which is fantastic. It's not quite at the level of surgery where you're done in 1 or 2 hours. But, it's really exciting to see men get back to work and back to life without having to be in the doctor's office so much.
Now, what's the difference between quote unquote regular radiation and proton beam radiation?
So photons and protons are just 2 ways of destroying the prostate and the prostate tissue. Photons are a little more precise. For childhood eye tumors, for example, you can stop and start these protons without penetrating brain tissue. With the prostate, it's, the prostate organ is built very badly in the middle of the male pelvis.
Well, it's built perfectly, except it's hard to get to.
And so you have to fire the radiation many different directions. And so we haven't seen any real added benefit of protons over photons in terms of side effects or cure rates. It's still an equal modality to cure patients, but not necessarily a superior modality.
Let's talk about what some of your colleagues have called a game changer, Pluvicto. And I see it being advertised on television. What is it? Why is it different? And is it a game changer?
So I earlier mentioned a form of PET scan that has transformed how we visualize prostate cancer. This PSMA, or prostate-specific membrane antigen, is fairly commonly expressed in prostate cancer. Only about 10% of prostate cancers don't have it. So about 90% do have it. And so if you can do a full-body scan and see where it's at, a way of treating it would be using the PSMA molecule almost like as a Trojan horse to deliver some smart bomb, a radioactive pellet, for example. Lutetium-177 is the Pluvicto treatment, but there's a lot of newer treatments using more potent forms of radiation or chemotherapies or immune therapies to target PSMA and other cell surface markers. And so Pluvicto is the first FDA-approved what we call radioligand therapy, so a form of radiation that's targeted selectively to the prostate cancer, and that extends survival. It doesn't cure patients, but it can put the cancer into remission without the need for chemotherapy or chemotherapy side effects. So a very popular treatment. Just a few months ago, the FDA approved this and extended the label to men who haven't had chemotherapy yet. So that's a very exciting development. And then just 2-3 weeks ago, there was a press release that a new Pluvicto trial was positive in a hormone-sensitive setting. So even before hormones have been given. So we haven't seen that data, but the more we use this weapon, the more success we're seeing, and we're continuing to evolve this as a way of being smarter, to be more selective against tumor cells with targets that are beyond PSMA, with other attachments, warheads, other than lutetium, like alpha particles or immune cells or targeted chemotherapy called antibody drug conjugates.
So you've described these as smart bombs because they go straight to those cells that are malignant. And that does seem like a game changer, but it comes at a price. How expensive is Pluvicto?
Well, there's a couple prices. One is the financial toxicity. Of course, it's covered by insurance. In our healthcare system, the price to patients is zero, which is fantastic, but the price to the healthcare system is very high. This emphasizes the need for cost containment for a lot of the medicines that we use in general. And in the field of prostate cancer, it used to be just several $100s to treat a man 20 years ago, and now it may be, approaching $1 million to
So
treat
even though the
patients.
treatment is more effective, it's drastically
The
more
price tag
expensive.
has gone way up, and you run into affordability issues. And in many countries, there's very much a cost-conscious approach to this, and where there's the ability to negotiate drug prices and things like that. So right now, Pluvicto can be $250,000 to treat patients to extend life by a few months, which is great for that individual patient. But as a society, I think we need to, think about, how we're pricing our medicines.
And a lot of insurance companies are going to say, whoa, wait. $250,000 for 6 months or a year, maybe? You have to fail everything before we will approve the treatment, such as Pluvicto. How do you, as a clinician, interacting with patients, how do you deal with that barrier that insurance companies will sometimes put up?
Yeah, fortunately, we don't see a lot of denials right now. I mean, our healthcare system has been quite permissive of a lot of our therapies. These pills are very expensive, often $10,000 to $15,000 a month. Immune therapy can be $100,000. This Pluvicto can be expensive. But when there are denials, I think, you push back on an individual level. Quality of life, can be important, avoiding chemotherapy and its side effects like hair loss and immune suppression and nerve damage, other goals that patients have. Some patients have dramatic responses. While an average might be 4 to 6 months of extra survival, you see some patients living many extra years of life.
What do you envision for the future? What's on the horizon?
I'm most excited about immune therapy in most cancers. We've seen breakthroughs of immune therapy in lung cancer and breast cancer and head and neck cancer and kidney and bladder cancer, but prostate cancer's been left out of that party. We have Provenge or Sipuleucel-T, which is a great immune therapy.
Mm-hmm. What are we talking about?
This is the only immune therapy for prostate cancer that's approved. Now, it does extend life and is very well tolerated, but it's over a decade old. We would like to move beyond that to the point where maybe we can eradicate some prostate cancer cells and
this would work by getting the body's own immune system to attack the prostate cancer wherever it is, right?
In many cancers, we've seen successes and durable remissions, even cures of stage 4 disease by engaging the immune system to do all the work for us. As you know from vaccines and infectious disease, that's what happens naturally, is to cure a patient of an infectious disease or prevent an infectious disease through the immune system. The same analogy is at play in cancer, but cancer evades the immune system through a series of checkpoints. Now, prostate cancer has its own series of checkpoints that we're still deciphering, but I think that's where we're going to see the greatest work in the next decade, is overcoming those checkpoints.
And we don't at this point have checkpoint inhibitors that work against prostate cancer?
Not yet. We've tested them and spent hundreds of millions of dollars testing the most common checkpoint inhibitors that work in other cancers to see them not work in prostate cancer. But we have a number of trials testing new ones.
What about CAR T, where we remove the blood from a patient, modify it, and then re-inject that back into the patient, and it's worked amazingly well for multiple myeloma?
For blood cancers, these genetically engineered T cells are fantastic. They have cured childhood leukemias and adult, lymphomas and myeloma. In solid tumors, they have not even been a base hit. The cancer evades these T cells, like I said, through checkpoints. The T cells don't even make it into the cancer. In prostate cancers, you don't even see T cells in there. They're actively excluded. And there's a number of other cell types that we need to overcome. So it is back to the drawing board, but I do see a great promise in that approach.
Dr. Armstrong, there's a lot of information out on the web. And so if somebody puts prostate cancer into a search engine, they will get so many different perspectives. Do this, don't do that. And at the end of that, they're probably going to be more confused than when they started. So how can we find trusted resources and be a little wary of misinformation?
Sure. The internet is a wild west. It's unfiltered. It's not peer reviewed. And there's a lot of people selling you things, where they have a clear conflict of interest over what they're marketing. So certainly as you are diagnosed with a condition like cancer, and you're approached by your doctor and you're talking to your doctor who has your best interest in mind, ask them about the individual sources. Now, for prostate cancer, there's a number of nonprofits out there like the Prostate Cancer Foundation. There's advocacy groups. There's patient navigator websites. The NCCN, or National Comprehensive Cancer Network, has a very patient-friendly website, American Cancer Society. You can use that as a starting point to frame this. Now, when I see a patient, I'm giving them additional handouts like downloadable brochures or books. People want to know, well, what to cook. There are cookbooks, for example, for men with prostate cancer.
Well, that's important. If we're talking about diet as a contributor to prostate cancer, you want to know how to change your diet so that you're less likely to have a recurrence.
Absolutely. It's very hard to just speak to this in a minute. It's all about a whole lifestyle change, exercise, just covering the basics of how do you exercise can be a complicated discussion.
So we've got diet, we've got exercise. Are there any other natural approaches that are helpful?
Well, the other day I had a patient who was dealing with severe hot flashes from hormonal therapy, and he found relief with an acupuncturist, which was amazing. This was a non-medical way of overcoming a medical symptom. And there are cooling bracelets out there that both men and women have used to overcome hot flashes. There isn't an alternative necessarily medicine to treat prostate cancer that you can reliably rely on. That's why it's important to look at these as complementary therapies. As long as they're not harmful or interacting with your medicines or toxic, certainly, bring these up with your doctor. I get a lot of questions in my in-basket and in person about individual questions from the internet. I'm happy to field those. Some are really not based on science or drugs that are not absorbed, but they get a lot of, press where a drug may work in a petri dish to kill a cancer cell. But in the human body, it's a whole nother story.
Dr. Armstrong, you are arguably one of the country's leading prostate cancer experts, and certainly you hang out with a lot of other cancer doctors. What will it take, do you think, to get medical centers like Duke University to contemplate exercise for cancer the way it recognizes the value of cardiac rehab for heart patients?
I think we already are. We've done exercise studies for prostate cancer for over 10 years now. We've published that exercise reduces, weight gain, improves muscle mass, improves cardiovascular functioning. This colorectal study, just demonstrated actually improves survival. We've seen that with breast cancer as well. I think it's starting to emerge as not just a side science, but a mainstream science where it can complement our existing therapies. We have an exercise therapy program at Duke. We have a Center for Living. We have ways to refer patients. We have exercise scientists. Some of this just involves going to the gym. It doesn't necessarily take anything super complicated, but just, investing in that time as a habit yourself.
And so as you sum up our conversation today, what would you like our listeners to take away, both in terms of prevention, early detection, and then ultimately treatment?
Thank you, Joe. The most important message is that prostate cancer can be picked up early when it's curable, that most men are cured of prostate cancer through early detection. So having that conversation with your primary healthcare provider to ask if you're a candidate for a PSA test and to be followed over time is really critical. That is the guidelines right now for certain age groups. The other message is even in advanced disease, there's hope. There's great treatments that extend life when surgery and radiation may not be possible or curative. We have a lot of new therapies coming. We have great advances through participation in clinical trials. It's really important to get second opinions, multidisciplinary opinions from not just surgeons, but medical and radiation oncologists, geneticists, primary care doctors are all part of the equation now as part of the healing process.
So if you get a diagnosis, ask to have a multidisciplinary team. You want an oncologist, a radiation oncologist, and possibly even the surgeon there. Let everybody weigh in that'll maybe come up with the best possible treatment for you.
Yeah, there's a number of great resources where you can go with prepared questions. The Prostate Cancer Foundation, American Cancer Society, the National Comprehensive Cancer Network can give you a series of questions to bring to your multidisciplinary team as you get second opinions and weigh what's right for yourself.
Dr. Andy Armstrong, thank you so much for talking with us on the People's Pharmacy today.
Thank you both, Joe and Terry. Thank you.
You've been listening to Dr. Andrew Armstrong, Professor of Medicine, Surgery, Pharmacology, and Cancer Biology. Dr. Armstrong is Director of Research at the Duke Cancer Institute Center for Prostate and Urologic Cancers, and he holds positions in the Departments of Medicine and Urology at Duke University.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
The People's Pharmacy is brought to you in part by Sonu, an FDA-cleared drug-free treatment for nasal congestion and runny nose, a sound-based alternative to steroids. More at getsonu.com. That's getsonu.com.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
Today's show is number 1439. You can find it online at peoplespharmacy.com. That's where you can let us know what you think about today's show. You can also reach us through email, radio@peoplespharmacy.com.
Our interviews are available through your favorite podcast provider. You'll find the podcast on our website on Monday morning. On this week's podcast, we discuss how to find reliable information online. We also talk about the importance of diet and exercise. Why don't cancer patients get the same encouragement for rehab and exercise that cardiac patients do?
At peoplespharmacy.com, you could sign up for our free online newsletter, and that way you can get the latest news about important health stories. When you subscribe, you also get regular access to information about our weekly podcast. You know ahead of time what topics we'll be covering. Speaking of the podcast, we'd be very grateful if you would consider writing a review of the People's Pharmacy and posting it to the podcast platform you prefer.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.